Thank you, moderators. I'm Jiang from Taiwan. It's my pleasure to present this topic. Patients with chronic urinary retention usually have low volume pressure in video urinodynamic study. Detrusor underactivity or undilated bladder can be observed in many conditions of neurologic insult or myogenic failure. Careful neurologic and urodynamic examinations are necessary. The pathophysiology of detrusor underactivity is unclear, and some novel treatment, for example, secondary stimulation, focus on modulating maturation reflex, and urethral bolus injection focusing on urethral sphincter function. But what we know is limited, so we try to use lower urinary tract electrophysiology studies to investigate these detrusor underactivity patients. We retrospectively collected 60 patients with chronic urinary retention necessary to receive CIC or urethral catheterization, and they were diagnosed detrusor underactivity in video dynamic studies, and we have excluded the patient with bladder outlet obstruction. They all received the lower urinary tract EP studies, and our electrophysiology study included 3 parts. The first one was the examination of bulbar cavernous reflex by electrical stimulation of dorsal nerve. And the second one was the needle EMG of external urethral sphincter, and we record and analyze the motor unit potential. And the third one was the nerve conduction velocity of pudendal nerve result. Total 60 patients included 10 CV8 patients, 35 after the lumbar sacrospinal surgery for spondylosis, 5 patients after radical surgery for cervical cancer, and 10 idiopathic patients. The mean age was 60.4 years old. There were 28 men and the others were female. A total of 31.7% patients had diabetes, and especially in severe group. By physical examinations, 31.7% patients had sacral neuropathy, and we defined the sacral neuropathy was sedal anesthesia, decreased anesthesia sensation, and loss of anal tone or decreased anal contractility, and the BC reflex detected by manual. And in our EP studies, BC reflex positive rate was 41.7%. In EMG study, denervation change were observed in 22% of the 22% of patients, exclusively in lumbar sacrospine surgery group and idiopathic group. The majority of these detrusor underactivity patients had re-innervation change and reduced recruitment of external urethral sphincter in EMG studies, and only 11.7% of patients had preserved good recruitment. In NCV studies, decreased amplitude of pudendal nerve was detected in 73.3% of patients. In video dynamic studies, detrusor overactivity is observed in 60.7% of the patients, and a majority of the bladder outlet condition during voiding was a non-opening bladder neck. And after excluding the patients with DM or sacral neuropathy in physical examinations, high percentage of neurologic insult were explored in our EP studies. And we defined the patients according to the presence of sacral neuropathy in physical examination or not. And we can find that the sacral neuropathy group had a younger age and lower positive rate of BC reflex, a higher denervation change in EMG study, and a higher rate of decreased amplitude of pudendal nerve in NCV study. And more important information was that in those without sacral neuropathy in physical examinations, there were a high neurologic deficit percentage was detected. And in video urinodynamic studies, patients with sacral neuropathy had a higher percentage of intrinsic sphincter deficiency. After excluding the diabetic patients, the result was similar. the patient without sacral neuropathy, there is a high percentage of neurologic deficit detected. High percentage of neurologic deficit in EP study were examined in these detrusor under-ATT patients, even in those non-diabetics without sacral neuropathy in physical examinations. Reinnervation and reduced recruitment of external sphincter in EMG studies indicate the status of lower urinary tract experience an incomplete or inadequate recovery from the potential neurologic insult. Decreased amplitude in NCV studies also suggested the presence of pudendal neuropathy. Above observation might play a role in predicting the treatment outcome in the future, especially in the treatment strategy focusing on the external urethral sphincter or maturation reflex. But there are some limitations in our studies, including lack of consensus for the definition of detrusor underactivity and heterogeneous etiologies. Aging is also an important factor in detrusor underactive patients, but the impact of aging in EP studies is unclear in our limited knowledge. This is a pilot study to analyze the muscle and neurogenic condition of external urethral sphincter with EMG and NCV studies. However, it cannot actually reflect or be equal to the muscle or neurogenic status of the bladder. But we think that lower urinary tract EP study has an experimental rule in this detrusor underactivity in the detrusor underactive patients. Conclusion: high percentage of neurologic deficit in EP studies was noted in the patient with detrusor underactivity and chronic urinary retention. Even within the non-diabetic patient without sacral neuropathy, high percentage of BC reflex, negative rate, reinnervation, and incomplete recruitment rate of external urethral sphincter and decreased amplitude in NCV studies were detected. Potential neurologic insult explored in EP study could play an important role in the pathophysiology of detrusor underactivity, and it may provide an aid in the treatment strategy in the future. Thank you.
Peter? I have one comment and one question. And the comment is, if you, one way or another, present this again, will you please present latency times and absolute values of the results that you got, and not only percentage abnormality? I do not know what is your definition of abnormality. My question is, if you found a sacral reflex, I think your definition is of abnormality is a long latency time between stimulation and reaction. And you found that long latency time were related to dyssynergia, the detrusor sphincter dyssynergia. Didn't you think that that was very unexpected?
In NCV studies, we can get two parameters. One is the amplitude of the detected wave, and one is the latency. But in our study lab, and the latency variation is very could not be normalized by. We can get the actual
time that you use as a cutoff for the bulbocavernous reflex. What's the latency time? What's the latency time that you use as a cutoff?
Latency time we used cutoff point was less than within 5 milliseconds.
Okay.
Yeah, but we define the decreased amplitude of NCV studies. We just quantitatively, not quantitatively.
Good. And the latency time of your evoke potentials?
Yeah.
What was the cutoff?
Cutoff 1 millivoltage.
That's the amplitude.
Yeah, less than 1 millivoltage. We define it a decreased amplitude.
Too detailed now. But The surprise. You were not surprised that you saw, with the long latency time of the bulbocavernosus reflex, this sphincter dyssynergia. One way or another diagnosed.
But in this...
I am. On the basis of neurophysiology and on the basis of what can happen in the neurological tract. Is Dr. Sakakibara here? No. Thank you.
Peter, I take your point, but the question is another one. Beyond the technicality of the diagnosis, we can acknowledge that we have patients with a weak detrusor, if you let me say so, because of a neurological damage. The problem is what to do with these patients, because if the problem is only that the patient is unable to empty the bladder and it builds up a residual urine volume over time, that's one thing. But if the patient has BPH, high PSA, chronic prostatitis, and a lot of symptoms, the problem is what you do, because you don't deal with EMGs. You deal with patients. You have the one their symptoms to be solved. Helmut.
Can I have the microphone? Is it on? It's on. Thank you very much. Marosław from Innsbruck, Austria. I think what you want is to differentiate between myogenic damage and neurogenic damage of an underactive detrusor, right, sir? That is your basic aim. Because it's a difference if I have underactivity or achondroplasia due to a myogenic damage, then even sacral neuromodulation, all these techniques are not useful. So you are your assumptions are based on the activity of the pudendal nerve, right? So bulbocavernosus reflex, EMG of the sphincter. However, you also have to consider that you may have a patient who has still a preserved bulbocavernosus reflex, but has still a neurogenic damage to the detrusor. I just think on patients having had a pelvic surgery. You get partial denervation of the bladder, yes? But the pudendal nerve is rarely affected. So you have a patient with and it comes to you with chronic retentions, maybe over half a year or a year. And now you want to know, is this a myogenic damage already due to overdistensions, or is it a neurogenic, or is it both? And I think the bulbocavernosus reflex in this specific group of patients cannot give you the answer, because he may not be lesioned by the surgery. That's very peripheral, as you know. And you do the surgery on the pelvic plexus.
Yeah, but I think that actually our electrophysiologists focus on the external usual sphincter. It could not actually reflect the bladder muscle condition or the contractility in the bladder. And actually, there's no useful tool to detect what we want to know about the detrusor condition. But actually, some treatment in these detrusor underactivity patients focus on the bladder outlet condition or the maturation reflex. So by what we know about the sphincter condition and the sacral reflex is too limited in these patients.
Yeah.
So I think that this study could provide some information about before that we perform the invasive treatment, for example, sacral stimulation or Botox injection, and if we perform this electrophysiology study, we can make a better prediction before the surgery or to avoid unnecessary invasive procedure in these patients.
So for differentiating between myogenic and neurogenic damage, I think we have to find other tools.
If it is a very quick.
Yes. My name is Jalesh Panikar from Queen Square. It's interesting, this discussion that when you do the electrophysiology test, you're assessing the somatic innervation. You're not assessing the autonomic or the parasympathetic innervation. I think that's been very clear. But what it does seem to suggest is that these group of patients who have an underactive detrusor muscle and also show evidence of denervation in the anal sphincter or in the other neurophysiology tests, seems to suggest that the lesion is somewhere in the sacral nerve roots, where the somatic and the autonomic there's a commonality there. And so it's a group of patients, I guess, where the MRI is negative. There's no compression of the sacral nerve roots, but there's a functional disturbance of the nerves which is responsible for what you see.
Okay, good point. I think that in the interest of time, we have to close. Thank you for your presentation.
Thank you.